All right, good morning. It's 8 a.m. Welcome to Coplow Rounds. We're going to go ahead and get started. Um, my name is Kelsey. I am one of the staff pathologists here at Coplow. Should open up this PowerPoint. There we go. And I'm going to start with the first two cases. So our first one is going to be the globe from a 2-year-old male castrated Maltipoo. And the history we received is the dog presented with a several-week history of ocular cloudiness in the left eye, which is this eye depicted here. The exam showed that this eye was non-visual with absent light perception. The eye was markedly inflamed, characterized by uveitis and hyphema, and retinal detachment was observed on ocular ultrasound. So here is our hemisection of this globe. We have our cornea up top, and here's our optic nerve head and optic nerve in the back here. And from this view, we can see a few things. So here's our anterior chamber. This is going to be the ventral aspect of the globe. We can see there's some settled hyphema in that anterior chamber, so some blood in there, as they saw clinically. Here is our iris. There's our other iris leaflet. And there was a true adhesion between the iris and the anterior lens capsule, consistent with posterior synechia. We also noted that there was this kind of tan material on the anterior surface of the lens, and there's kind of this little bleb of tissue right here. And our lens is a little bit cloudy as well, so this could be a cataract. We also noted the vitreous was a titch cloudy as well. We can still see through it though to see the retina, and at least grossly, we don't see an obvious retinal detachment. There's kind of sometimes this little like areas of wrinkling, though we can see that as an artifact as well. So hard to comment on the retina at this point. We'll look at it histologically. And then our optic nerve head looks relatively flat. They clinically did note glaucoma, so we'll keep that in mind as we look at this histologically. So we will move to the slide. And then I'll just start with subgross. Always a struggle for me. All right, so here's our subgross view. We have our cornea up top, and then back here is our little optic nerve head. We also have another little radial section of the eye. We just include that to look at more views of the iridocorneal angle. There are some little Sharpie marks that maybe we'll come back to. So let's see if I can hold this with my left hand. There we go. So we do see there are some red blood cells in the anterior chamber consistent with hyphema. Cornea looks a little bit busier. We can look at that more closely. Here is our iris. We can see those leaflets are indeed adhered to the anterior lens here, consistent with posterior synechia. We also do this anterior bowing of the iris leaflets. So this is iris bombay. Lens also, we can see there's a little capsule right here, and there's definitely more cellularity within the lens as well. So we'll look at that more closely. And then moving back, we have a little bit of vitreous left. It's maybe a little bit more proteinaceous, which could have contributed to that cloudy appearance we noted grossly. As we go back here, we do have some artifactual retinal loss, so probably just didn't come into section as this was being put on the slide. And then our optic nerve head looks fairly unremarkable. Right. All right. So now we got one more. This globe is now flipped 90 degrees. So cornea is going to be on the right and our optic nerve head is going to be left. And got the corneal stroma. There is a good amount of vascularization as well as some fibroplasia. So we kind of have this more dense collagenous tissue. Replacing the stroma over here is kind of more normal corneal stroma. It's a little more loose looking. And as we move in this direction, we do have this kind of more paraxial area where there's also fibrosis. So these are all fibroblasts, loose fibrous connective tissue. And we also have this break in Descemet's membrane. As we follow that little gap of fibrous tissue, then we pick up Descemet's membrane again. Moving back to our uvea. Iris, there's a little bit of stromal inflammation, mostly lymphocytes and plasma cells, which is fairly nonspecific, but it's there. Let's move back to our lens. We have a couple of areas of lens capsule discontinuity. So we have a lens capsule rupture. You have kind of these liquefied lens fibers that are protruding outwards. And covering up this anterior lens capsule, there is also this kind of fibrous membrane, and within that membrane, just a ton of inflammatory cells. So neutrophils, we have a lot of macrophages and multinucleated giant cells, kind of a more pyogranulomatous inflammation surrounding our lens. What I thought was kind of fun is are these little areas of partial discontinuities. It almost looks like a mozzarella stick getting pulled apart right here. And as we move into the lens, actually look at our lens fibers. We have a decent cataract, as suspected grossly. So let me move in this way more. So there are areas where maybe we have the normal kind of lamellar arrangement of our cortical lens fibers. So over here, they're kind of fragmented artifactually. But then there are a lot of areas where we have cataractous degeneration. So we see liquefaction of those lens fibers and they form these globules called Morgagnian globules. And we have areas where there's nuclear retention. So we also have bladder cells, which are hallmarks of cataract. Additionally, within here, we have tons of inflammatory cells, kind of similar to what we saw earlier. So mostly neutrophils. They're pretty fragmented in this case, as well as some foamy macrophages. So we have a phakitis, which if we didn't see the lens capsule rupture, we could, having seen this inflammation, say there definitely is a lens capsule rupture because inflammatory cells should not be able to get into and through an intact lens capsule. So these findings, this kind of lens capsule rupture on the anterior surface, and all this inflammation in here, as well as this perilenticular inflammation, should maybe cue us into a specific condition that we see. And it makes us want to go on a bug hunt. So in this case, let's see. Let's just go to the other one. There are some areas where there's this very suspicious stippled material. A little hard to see what that is. So I'm going to go across to our other radial slice where I have my dots. And in here, ooh, the resolution also kind of poor in this case. I guess that's the 60x. I'll go back one more. There is more convincing bacterial growth here. So these little, you can kind of see these little round foci. So all of these are bacteria. So this picture, this histologic picture, where we have phakitis, we have this kind of perilenticular endophthalmitis, and we have intralenticular bacteria, is all consistent with a condition we call septic implantation syndrome, in which there is a penetrating trauma through the outer fibrous tunic and into the lens through the lens capsule. And with that penetrating trauma, it seeds bacteria into the lens. That bacteria kind of simmers for a little bit, and then the eye explodes with inflammation, often within and surrounding the lens. In most cases where we actually receive the specific trauma or the history of that trauma, the usual culprit is going to be a cat claw. And I feel like we usually see this in younger dogs. Like this case, this dog was 2 years old. I feel like maybe they're just more curious and playful, and maybe their housemate does not like that.
That's experience in life.
Yes, yes.
Or naive.
Yeah, naive is probably the right word. And I do wonder, we have this little area of fibroplasia. We have a break in Descemet's membrane. This could be that site of penetrating trauma that we're kind of capturing tangentially. So we kind of have our path through the cornea and then maybe up through here. Usually we have kind of an arc of the cat claw. And then some cleanup. Posterior segment is relatively unremarkable. So they did mention retinal detachment. And in most cases where we can see the retina, it doesn't look overtly detached. So we still have kind of a normal, our normal photoreceptor segments, and our retinal pigmented epithelium also looks pretty unremarkable. Usually we'll see hypertrophy of the RPE with more long-standing detachments. However, in this section, there's this area peripherally where I would believe there's a true detachment. So in the subretinal space, we do have this more proteineous fluid, which helps corroborate. When we have material in the subretinal space, it helps corroborate that there was a true detachment. In this case, these photoreceptor segments look a little bit more blunted and atrophied, which does corroborate there are foci of retinal detachment. And then they also mentioned glaucoma in this eye, which in most areas where we can see the retina, it still has a good number of ganglion cells. There's a little bit of a retinitis. Over here, we can also see kind of ganglion cells here and there. And then our optic nerve head also doesn't look particularly atrophied, which just means histologically we can't confirm that there's glaucoma. It doesn't mean clinically that there was not glaucoma, though. There's a number of reasons where we have a discrepancy between the histologic appearance of the retina and optic nerve head and the intraocular pressure. So with that, move over to my diagnoses. So kind of cleaned up diagnoses, but bottom line being that our constellational lesions are most consistent with septic implantation syndrome, which is good news for the systemic health and the health of the other eye for this dog. But unfortunate that this one had to get removed. All right, if there are no questions or concerns, I can move on to the next case. Very cute clinical photo. So this one, we have clinical and gross photos. Thank you to the clinical team for these nice photos of this very adorable patient. So we received both globes from a 14-day-old female intact Nigerian dwarf goat. And the history received is that the globes were bilaterally exophthalmic. There's inability to blink or close the eyelids completely. These eyes never appeared to have vision, and no menace response was ever seen. And they specifically say that they did not observe kidding, so the birth of this kid, but there was no excess swelling or trauma to the doe, so presumably a normal kidding event, and the sibling was normal. And both of these eyes have been affected since birth. Otherwise, this goat kid has been systemically well with no other health abnormalities, just the globes. So here are images. So of note, we do have normal eyelids, but we have this kind of reddish desiccated tissue protruding from the orbit, which presumably is ocular tissue, but we will look at it grossly and histologically to see exactly what this is. Of note, I feel like looking at this, we're tempted to say, like, is this pupil? But remembering that goat pupils are going to be horizontally oriented. This looks more like a cat eye almost. It's kind of fun.
I have a theory that that's how those tales about like the chupacabra and things like that they come to exist because of congenital abnormalities like that, or abnormalities like that.
I would not want to run into this goat kid in the woods
Right.
at night. That's true. I would be very scared. All right. Yeah, that's true. Poor guy. Here are our gross photos. It sounds like the person who trimmed these globes went on a little bit of a journey figuring out what tissue we had,
Yeah.
which is understandable, I think. It is a very confusing tissue. So up top here, we have some eyelid. We can kind of see some little hairs coming out. And then over here, we also have our eyelids up top. And it turns out, so when we hemisected this, what we found was this large cystic space. And deep to that, adjacent to the cystic space, there's kind of this pigmented tissue. So what we came to conclude was probably this is ocular tissue, and this is just a cyst. That's what was seen protruding out of both orbits. And this one, we have a little bit better view of that, what is presumed to be ocular tissue. That's kind of peeking into this large cystic outpouching. And if you're confused, get ready. The histo is just as confusing. Let's see. Let's start with the right eye. And if we have time, I can show the left. This is one where I think subgross would be very helpful. So I'm going to do it. Let me flip it the other way. I'll have you all ignore my scratches here on the cover slip. That's my calling card. Okay. So, at top here, this is presumably our anterior face of this tissue. We have our eyelids. We can see some haired skin. We have what I imagine was the anterior surface or ocular surface right in here. We have this little fornix that's filled with stuff. As we move back, if this let me move back, like that. There we go. We do have some glandular tissue and maybe a little bit of cartilage, so something reminiscent maybe of third eyelid. And then this is the bulk of that tissue, is this large cystic space. We'll go closer to look at the finer details of that. And then as we move to the very back, or maybe to the very side, we do have some recognizable ocular tissue sitting within this chamber that is confluent or continuous with that cystic outpouching. So we do have something that looks like lens, something that looks like retina, not much else in this section. Okay. No, I do want it this way. Never mind. Okay, so similar story where the globe's been, or whatever this is, has been flipped 90 degrees. So again, we have our eyelid. We have this weird kind of ocular surface. This is also eyelid that maybe we could kind of peel back out this way. And then we have all this shmoo that's sitting in what I guess we would call a fornix and kind of on the surface of this tissue. And it's just this kind of serocellular crust. There's a lot of dead neutrophils in here. There's this kind of foreign debris. Sometimes these are probably little hair shafts embedded in here. And I'm sure there's bacteria in here as well. There we go. Just a bunch of bacteria also sitting in this crust, which maybe this was that vertical black line we were seeing on the surface.
Yeah.
Feasibly, this should be cornea. It doesn't look like cornea though.
Yeah,
There's
that's
this-
very misleading, that image.
Yeah.
It's like
Oh, it
eyes,
is. I'd
yeah.
agree. So we do have this fibrous tissue. This does not look like corneal stroma. It is inflamed. There's some neutrophils in here. And we have this really thick keratinizing stratified squamous epithelium. It's nothing that really particularly resembles cornea, nothing that this goat was going to be able to see through, even if this eye was visual. And then we have this tissue that kind of resembles third eyelid. We have our gland. We have this cartilaginous structure. Adjacent to that, we have this little baby cyst that's lined by what looks like conjunctival epithelium. We have this columnar epithelium. There's a bunch of goblet cells interspersed with it. So we have elements of conjunctiva, third eyelid that are trying to form but didn't quite make it to their proper locations or in their proper configuration. Then we have this large cystic space. As we look closer, it is a true cyst, so it's lined by cells. It has a cyst lining. And this is what we call neuroglial tissue. So it almost resembles like a very atrophied retina. So it kind of has this neural component. I assume if you did a glial cell IHC marker, these would probably light up. So if we did a GFAP, it would probably show that most of these are glial cells. And sometimes we have these fun little kind of eosinophilic globs in there, which we'll revisit. Then we'll move back to actually look at our ocular tissue. So here is our lens. There is a decent cataract, so we have more of those Morgagnian globules, we have bladder cells, and it's rather extensive. Let's move around. We have a lot of mineral in here as well. And there are areas, I don't know, yeah, this particular section isn't most convincing, but there are areas where there are discontinuities in the lens capsule as well. I can show that in other views. With lens capsule discontinuities, we generally think about them as traumatic or spontaneous. We can see some congenital entities where there is we never see like a actual formation of that lens capsule, or we see like a weakening and eventual rupture of that lens capsule. I suspect given where this globe was in the orbit, it probably did not sustain trauma. I feel like we had that cyst absorbing a lot of shock if there ever was trauma.
That's a good
Yeah.
point.
And then we have this kind of more convincing retinal tissue that is notably not attached to anything. It's kind of just globbed on to the lens. And we do have recognizable structures in here. So we have these little kind of coffee bean-like cells that are probably the outer nuclear layer. These are probably inner nuclear layer. Coffee beans. It is the morning. And I feel like somewhere in here, there is kind of some convincing ganglion cells too. It is very jumbled up though, kind of hard to recognize those distinct layers. We don't have the normal stratification. We oftentimes have these little rosettes forming in that outer nuclear layer. So this is a dysplastic retina. And presumably it is detached here. This may represent a congenital non-attachment where this neurosensory retina never opposed the RPE in the first place. In some cases, it's hard to discern between acquired detachment and congenital non-attachment. Given the context clues in this case, though, I believe that this is probably congenital. And then as we go over here, we have more of those eosinophilic globules in the retina, and they kind of resemble our lens fibers. So this is what we call lenticular metaplasia. Sometimes people call these lentoid bodies. Why they're here in this case is kind of unclear. We have associated with trauma in other species like birds. Not quite sure why they're here. It does seem like maybe they're also within that neuroglial lining in areas. So kind of just an interesting finding in this case. Significance unknown. And then also in here, we do have some structures that resemble maybe extraocular muscle. I assume they weren't doing much in this eye. Then we just have orbital adipose tissue. And I'm just going to put on the other half of the right eye really quick. Flip it around, which has similar things going on. We have that third eyelid. As we move back to where ocular tissue was, we have areas that are a little bit more convincing of uveal tissue, just to complete the layers that we have in this eye. So we have this pigmented epithelial tissue, so some part of the uveal tract. A little hard to say who it is at this point. And then also next to that, we also have some nervous tissue. So presumably representing our optic nerve head and optic nerve. Sometimes there's like these weird little, what I think are just cells of the retina embedded in there. There's like a little, there we go, rosette in there. But overall, it looks like optic nerve. Time is it? No, I'm totally out of time. So I'll just say the left eye was very similar to the right eye. Some slight differences in just how things were organized, but overall, just a lot of congenital anomalies. So I'm just going to move over to our diagnoses. So in both eyes, we ended up calling this a microphthalmos with cyst, which I like this name because it describes exactly what this entity is. It's a congenital ocular anomaly where there's a small eye and there's a cyst that forms in the orbit. And it is thought to be due to defective closure of the embryonic fissure during embryologic development of this eye. So typically what we'll see is those ocular structures will be underdeveloped, and then there'll be failure of closure of that fissure, which then forms this large outpouching or cyst in the orbit. And there's a lot of things that factor into development of this syndrome. And it can be associated with systemic signs in humans, or it can also be non-syndromic, so it's just limited to the ocular tissues. In this case, they say that this goat kid is otherwise systemically well, so I would hope that this is just limited to both of the eyes, and hopefully the kid does well going forward. And then the left eye, there were areas that look like anterior segment dysgenesis. In the right eye, as you saw, it's kind of hard to find an actual iridocorneal angle to say anything about it. So it's possible this is also bilateral. And I think that is it for this one. Just a lot of, crazy congenital anomalies.
I was just thinking about the lenticular metaplasia.
Yeah.
We see as a response to trauma most often in the lab, but it can be kind of a choristomatous sort of change. There's a lenticular choristoma in humans where they end up developing lens-like material sort of in a conjunctiva and periocular. So I wonder if in this case, instead of a traumatic induction of like Miller cell metaplasia, it's more like a congenital,
It's an issue with like signaling and
malformation on the retinal tissue itself.
I would believe it. Yeah.
But it is interesting.
Yeah.
You've checked a lot of those, Gillian. Do you remember seeing that diagnosis in congenital things or more traumatic things? Remember that poster put together for, I think, ACVP a while ago?
Lenticular metaplasia. Oh, in mammals, it's mostly like weird developmental things.
Okay.
But then like the occasional like a horse that has like a vegetal epithelioma will have it in either in the tumor or in the retina.
Trauma, right, in birds and
Trauma in birds for sure, but not trauma in mammals.
okay.
Good to know. Okay.
That's good. Developmental.
Yeah, so that makes sense.
Okay. No. For those that didn't hear that, so with lenticular metaplasia within the retina, typically we associate that with trauma in birds. In mammals, it does seem to be more associated with like developmental anomalies, as in this case. So that's a good explanation. All right.
Dr. D might disagree. I'm trying to remember cases now. Like, well, did we get some that were quiet? Yeah, I don't know. Hard to say.
Okay.
Anyway.
An interesting finding. Right. And with that, I'll hand the scope over to Dr. Clemens. So he sees.
It is screaming dog. Now we have a crying cat.
A lot of emotions as well.
Two cutie patooties. Okay. This cutie patootie, I'm Megan, sorry, introduced. This cutie patootie is a 10-year-old neutered male domestic short-haired cat. Let's see. Here we go. History of a blocked nasolacrimal puncta of the left eye and chronic serous discharge. It's serous discharge. Serous discharge diagnosed elsewhere when he was young. So he has had a pretty long-term history of blocked nasolacrimal puncta of the left eye, an increased like tearing or serous discharge. But then more recently, ventromedial retrobulbar mass of the left eye, appearing to grossly occupy the medial orbit and extend to the medial lower eyelid. Small conjunctival mass noted in the area of the medial caruncle. Third eyelid is slightly raised but demonstrated normal movement, and the medial canthal mass associated with the third eye was unassociated, sorry, with the third eyelid movement, so I don't think it's linked to the third eyelid itself. Non-painful on palpation, and upon opening the mouth. Yeah, so that's the main thing. They did do a CT scan, which revealed a mass confined to the ventromedial orbit, with extension of the mass into the nasolacrimal duct, and a bit of pressure necrosis on the medial orbital bone, but no infiltration of the bone noted. So we have this clinical image. You can see our left eye has that ventromedial swelling. You can see the serous discharge. The eye itself is looking pretty okay. And then in addition, we have some findings at surgery. So here is the kitty's nose, and here is lateral canthus, and so we're kind of at medial canthus here, and they've excised into that area, and you can see what they'll have described in the surgical report there. So they describe it as, upon excising the medial canthal mass, entrance into the medial orbit was achieved, and yellow to white to pigmented, soft, circular to amorphous, small, about 5 to 10 millimeter masses were expressed with gentle pressure from within the orbit. Ooh. And then a mild to moderate amount of purulent material was also expressed initially when excising into the mass. So these are those sort of soft structures that they were expressing from the site. Kind of this like tannish, yellowish little doodad here, which you can see. And you know, to help orient as well, here's the leading edge of the third eyelid. So that's initially what we got, and let's take a look at some histology. All right. So these are the tissues that we got, and a lot of what they submitted were those sort of soft tan yellow thingies that were expressed from the area, which are represented by these weird doodads histologically. These are all very scientific terms. We also have some tissue that looks more like it comes from the patient. So we've got some collagenous stroma, we've got some glandular tissue, we've got some epithelial surface. So we're looking at kind of some conjunctiva that's near the medial caruncle, where it sort of blends into like sebaceous glands directly from conjunctiva. But we're going to focus mostly on these weird amorphous doodads. They're so cool.
They are.
For a pathologist. So we have this sea of neutrophils and a little bit of hemorrhage surrounding these amorphous conglomerates of stuff. I like the word conglomerates. And they're kind of finely stippled or granular looking on closer inspection, although it's hard to resolve individual stuffs that may be going on in here, using very scientific language as I go through. So that's what we're looking at here. And I'm, without further ado, going to show you what happens when you throw a gram stain at that. Look at it.
This is crazy.
There's some bacteria here.
A new control for the histolab.
Yeah, we got a new control.
Genuinely.
Yeah, so there's some bacteria in these conglomerates. There's a few. It's subtle, yeah, but you can see it. There's a titch, just a titch. So these bacteria are filamentous. We have, oh, I can probably zoom in. Oh, that's as close as I can get, actually. Oh, with the mouse. I forgot about that. Even though you guys reminded me. This is the best we can do, I don't know. So it's filamentous and kind of branching. A feature that kind of actually threw me off a little bit. See how there's kind of little stippledy dit dots admixed as well? Most likely, as it turns out, those are probably end-on sections of the same filaments. But there are other species of non-filamentous bacteria that could potentially produce these massive colonies, and that's what these are. These are giant bacterial colonies, basically. So streptomyces might be one that could be more of like a cocci in chains, but it turns out this is filamentous. And if you see these structures, which are sometimes referred to as sulfur granules, the reason being that grossly, I guess if you're familiar with looking at sulfur granules, maybe you are, maybe you aren't, they kind of look like granules of sulfur. But yeah, those kind of yellow tan little structures are sometimes referred to as sulfur granules for that reason. And what they are is just giant colonies of bacteria, usually associated with like polysaccharides and like stuff the bacteria is producing, maybe like immune complex deposition and all that sort of stuff. So when you see these sulfur granules, I think some of the main bacteria you can think of are those in the order Actinomycetalis. So your Actinomyces species and your Nocardia species. But Streptomyces species could also be on your list in terms of a cocci in chains. But we love clinical corroboration. They did do culture on some of these sulfur granules, patient side as well, and they did get Actinomyces species cultured. So we have confirmation, and we love that backup. I'll also just tell you verbally that these guys were acid-fast negative. So to distinguish between actinomyces and nocardia, nocardia may be weakly acid-fast, but may also be acid-fast negative. So, I threw an acid-fast at it, may as well. Negative. So there we go. We got gram-positive filamentous bacteria that turns out to be actinomyces confirmed by culture. In this case, the cat may have had an existing dacryoadenitis. This inflammation was kind of centered around the nasolacrimal duct by imaging at least. Didn't really get any obvious lining of nasolacrimal duct in our sections, but it's probably pretty distorted in the area by now. And maybe a secondary infection would be what I would wonder. Typically, these types of filamentous bacteria are saprophytes. They're kind of in the environment, breaking down, debris and things like that. So, and occasionally they can cause infection, often localized infections. And they tell us that the cat is doing very well after having that area kind of cleaned out. So that's good news too. That's it. Just a really cool example of sulfur granules. I love those. They're so pretty. All right. Here's the next thing. Make it bigger. F11. Whoops, it didn't like that. There we go. So I did, yeah. Said I would. So this is a 5-year-old intact male pug. So we didn't have a gross photo of this one, and I attempted a representative gross photo. It's probably not all that representative of what this patient looked like, but it's the one I found in portfolio. Let's see. So the main thing is that both eyes in this pug had a pigmentary keratopathy and mild qualitative tear film deficiency in both eyes. So this pug is being a pug. And they did note that both eyes were being treated with tacrolimus at one point, so immunomodulatory therapy, which is important for later on. In the right eye, that therapy was more recently discontinued, and they were looking at this sort of proliferative tissue that was starting to cover part of the cornea. So they excised this proliferative tissue from the cornea and gave us that. And that's the main thing that we got in this case. So our representative gross photo is just showing off a very thick and opaque looking cornea. It's more likely that our tissue would have looked more like opaque and like a discrete like bump in our specific patient. But that's what we got. And we're gonna look at the histology. What guy in the corner? I don't know what you're talking about. All right. So that's as low as we can go. Let's do a quick subglucose. Just quickly. So here's what our keratectomy specimens look like. They're pretty remarkably thickened. We have a lot of edema in the superficial stroma in particular, sort of this clear space, and then we have a lot of cells deeper in, and then maybe the hints of more normal corneal stroma along the deeper aspect. If we look at that closer, we have some areas of erosion to ulceration of that epithelium. We have that edema again. The rest of the epithelium is hyperplastic. We've got these deep radial pegs and keratinized. And we have tons of inflammation and essentially granulation tissue forming in the stroma. with deeper, more obvious remaining corneal stroma that's a little bit more normal, but still pretty heavily inflamed and vascularized. And you don't even really need dots because theoretically, knock on wood, because as you zoom in, our thing of most interest should immediately pop out. Should do. I know, watch me not find any somehow magically. No, there. Come on. Oh my gosh. They're everywhere. Dang it all. I do have a dot
Right
somewhere
there.
though.
Oh,
Okay.
you got the one on the epithelium, right?
There we go. Here we go. Yes. There we go. I will use the mouse zoom thing. In fact, I may already still be zoomed in. I'm still zoomed in. That's part of it. Okay. Flip condenser. Thank you. All right. Here we go. We'll get a good look at these guys.
There.
Look at them. They're so cool. That's as close as we can go. We can do the mouse thing. Here's the mouse thing. So these guys are likely in an epithelial cell. They're sort of oval shaped to maybe crescentic, maybe like 1 by 3 or 1 by 4 micrometers or so. So these guys, long story short, are protozoa. So we have a ton of protozoa in this cornea, and you'll find them in most likely macrophages in the stroma, and we found some in the epithelial cells, or presumably epithelial cells, more superficially. In terms of corneal or conjunctival protozoa, you can think about toxoplasma, maybe Neospora, leishmania, and trypanosoma. Kelsey helpfully pointed out that leishmania and trypanosoma, the amastigotes of those guys, would theoretically just be in macrophages, maybe a few other cell types they've been documented in, but they probably wouldn't be in the epithelium. So this may actually more likely be like a toxoplasma or something like that. We do have a link between ocular surface protozoal infections and immunomodulatory therapy chronically in the cornea and chronic inflammatory conditions. So it kind of checks out with this patient with chronic corneal inflammation and immunomodulatory therapy. I don't have the special stains back yet, but they're still pretty cool to look at. And then if you were wondering about the little dancing lollipop in the corner originally, now we'll circle back. I probably should have put that thing on the second slide, really, if at all. But anyway, it's fun. So if you are thinking about leishmania or trypanosoma, theoretically, if you can see the kinetoplast in the first place, leishmania has a kinetoplast that's oriented sort of perpendicular to the nucleus, or sorry, parallel to the nucleus, and or other way around. Basically it looks like the nucleus is like sitting on top of like a stick that is made from the kinetoplast, if you will, which looks like a lollipop. And then trypanosoma is the kinetoplast oriented as if the nucleus were like sitting on top of the kinetoplast, which looks kind of like a top hat. So that's your mnemonic, that leishmania looks like a lollipop and trypanosoma looks like a top hat. Which I am very amused by, but sometimes doesn't really help you at all because you may not be able to see the kinetoplast very readily in histologic sections. And even if you do see it, it might not be obvious in what way it really is oriented towards the nucleus. But it's a cool mnemonic anyway and might help you. So there's your mnemonic, the top hat lollipop.
So we have some comments here. Carol Naranjo, Carol did her PhD with leishmania in the eye. So, and she's saying that it may be too elongated for leishmania, but obviously hard to say. And like that, Dr. D is chiming in here and commenting on the fact that these are localized infections and these animals do not develop systemic disease, systemic infections.
Also a good point.
And since we're here, we got the hive mind out there. Any of the pathologists that have more experience with protozoans, they might be tuning in. Do you guys have any idea of the usefulness of using the location of these organisms to try to differentiate one species from another? Meaning, if you find them in the epithelium versus in the epithelium plus macrophages, would that lead you guys towards one or another diagnosis? I would love if we can. I thought it was an amazing idea from Kelsey, and I would love if we can use some of those things. Just let us know in the chat if you have any thoughts about it.
I was doing some digging, and like amastigotes can sometimes be found in other types, like fibroblasts or
Right.
things like that. And I mean, you could say they could probably be in like dendritic macrophages, maybe, but like this really looks like it's in the epithelium. And I mean, I agree with Carol Zaranjo. They're kind of like oval. They almost look more like bradyzoites of like a toxoplasma, or maybe tachyzoites. Yeah, maybe the shape and the size plus the location in cell types tips us off in this case towards maybe more like a toxoplasma.
Yeah, Carol agrees with you. Megan said what he said is true. Leash usually with macrophages, but it has been reported in other cells, not epithelial cells that she could recall.
Yeah,
That's
I didn't find epithelial cells either, noticeably. So yeah, I think Kelsey's idea is a good one.
all right.
Awesome. That's it. I can show you the diagnosis if you want. There it is.
I know.
Make it big. Oh, make it bigger. Here's the button. All right. Okay, so that is the two that I had. Next is Gillian Shaw with some more cases for us.
Nice colors.
Strawberry filled chocolates.
All right. This first case is a 2-year-old cat with a history of suspect congenital intraocular disease and glaucoma, globe rupture, retinal detachment. So there was a high IOP prior to rupture. Duration of problem greater than 2 months. The other eye is normal. All right. So we got the globe, and let's see here. We thought it was kind of a small globe, and in fact, when you look at the ruler down here, this is 1 centimeter. So most cat eyes of an adult cat would be, oh, I don't know, probably about 2 to 2.5 centimeters in diameter-ish. Just at a guess. So this is a smaller globe. Let's see here. We thought there was a dorsal perforation of the cornea, which is a little bit hard to orient ourselves here. At any rate, the lens was not recognized grossly. And yeah, so the globe is a little bit collapsed. So when we look at our image here, the cornea is at the top and it is opaque. And that is true. So formalin fixation does not cause corneas to become opaque. So when you see a cloudy cornea, that's typically a real thing. And we don't have any kind of anterior chamber. So we have iris that's plastered up against the back of the cornea, and the anterior chamber is completely absent. This red stuff here is some hemorrhage, and I'm not sure exactly why it's forming this weird little stalk here. The lens should be about right here in the globe, and it is not there. And then back at the back of the eye, we have some thick, what looks like thickened uveal tissue, and this bright white area right here is the tapetum. So we have a very distorted eye, and actually when you follow the sclera up and around, it is discontinuous right here. So I think that was the area of perforation. And we have two sections at 2 different levels of the block. I think it's small enough that we're just going to go right here. So all right. Oh, there's the back of the eye. This is our optic nerve right here. So we'll come back around to that, work our way forward here. So right here where I said the sclera is discontinuous, so there's sclera, and then here is cornea, or the artist formerly known as cornea. And there is this defect here. So that was the area of perforation, or the defect that they noted clinically. And let's see if we can find, here we go. Here's some more normal looking cornea. So we have corneal epithelium, corneal stroma, which is vascularized. It's a little bit maybe denser and more brightly eosinophilic, so that's pretty much consistent with corneal fibrosis. And then actually at both sides of the eye, we have replacement of the cornea with this dense collagenous tissue with a bunch of spindle cells in it. So this is fibrosis, more recent fibrosis, fibroplasia. And what we are lacking across the cornea is Descemet's membrane. So Descemet's membrane should be right here somewhere, and it's just not there. And what we do have is disorganized iridal tissue. Here's a little bit of smooth muscle of the iris, but the iris is blending with that deep corneal stroma diffusely. We have a little bit of inflammation in the iris, so we have a little bit of an anterior uveitis. There is some hemorrhage in the ocular chambers, which where we are right now is technically the posterior chamber because the anterior chamber is completely collapsed. And that is the majority here. So we are lacking lens in its entirety. It is not present anywhere in this eye. We also don't have lens capsule. We do have sort of hyperplastic and somewhat disorganized ciliary body plicae and tissue iridociliary epithelium that project posteriorly and kind of blend with this tissue that's right in front of the optic nerve. So in here we have some little islands of very degenerate or atrophied retina, and then we have some collagenous tissue or some fibrosis. I pointed out the tapetum in the gross photo, and that's what this is here, this kind of brownish tissue right here. So that's tapetum, and it's quite thickened. There's a little bit of inflammation around. And in here is the retina, believe it or not. So here's a ganglion cell right here, and some of these are the retinal neurons. They're probably a mix of inner and outer nuclei of the inner and outer nuclear layer. So photoreceptors and the other second order neurons. And the optic nerve back here is looking relatively okay, actually. So that is the majority of the lesions of this eye. We have a very abnormal eye, and really the posterior segment is quite compressed. So here's the ciliary body plica, or one of the more posterior ones. And then you can see that that distance from here to here is quite small. And we have a little bit of scleral wrinkling. So this could be some degree of thesis bulbi. And it's kind of a similar story over here, where we have iridociliary epithelium and then transitioning into the choroid and the tapetum. So the whole posterior segment is quite a bit foreshortened. This could be an acquired change. It could also be a congenital abnormality. My bias in these cases is that many of these are congenital abnormalities. However, in cats, we also have to keep in mind the possibility of feline herpes virus related severe corneal disease, especially in a young cat. This was a 2-year-old cat with at least a 2-month duration. So we don't actually know how long it had been like this. But feline herpes virus can lead to really significant corneal disease. And we think that it could potentially cause lesions like this. In this case, with the complete absence of Descemet's membrane, I'm really more inclined to be a little bit more suspicious of something congenitally wrong with this eye. So let's go to my diagnoses now. There's a bunch here, but I thought they were somewhat important. So the most important one is up here at the top, diffuse Descemet's membrane absence with associated broad anterior synechia and anterior chamber collapse. So my differentials are the result of feline early life ocular disease, which is the herpes virus related severe corneal disease, versus congenital abnormality, like something like Peters anomaly or anterior chamber cleavage syndrome or something like that. It is really difficult to tell the difference between these two. Both of these different diseases can be bilateral. However, they reported that this patient's other eye was normal. So whatever is wrong with this eye probably is not affecting the other eye. So thesis bulbi versus microphthalmos. I can't tell if this was a congenitally abnormally small eye versus shrinkage of the globe due to the other lesions. And then we've got some corneal epithelial hyperplasia. I didn't really get into that on the histology there. There's some intraocular fibrosis. Aphakia means lack of lens, and I'm not sure if this is due to extrusion.
through a corneal defect versus true congenital absence. And then diffuse retinal detachment and marked atrophy. I know it looks like it's not actually detached, but it surely was not opposed to the actual choroid. So it's kind of surrounded by fibrosis there. And then iridociliary epithelial hyperplasia, which is something that we see really commonly in abnormal cat eyes with this sort of constellation of lesions. There's something where the iridociliary epithelium seems to kind of go crazy. So this is just an interesting case. My bias is that this was probably a series of congenital abnormalities, but I can't rule out the possibility of some sort of feline herpes virus related disease. And that could have actually occurred in utero. It could have affected the cornea during development. So it's sort of both a congenital problem because it was present at birth and also, well, anyway, so a herpes virus related thing could be a quote unquote congenital problem. So I guess we're talking about congenital, meaning present at birth versus a developmental problem. And I can't tell the difference. Okay, cool. Let's move on to the next case. I've got enough time. This is a dog. This is an 8-year-old mixed breed dog. The history we got was, it's an extensive history. Moderate exophthalmia, moderate marked dorsal episcleral infiltrate / swelling with overlying marked conj hyperemia. And let's see here, markedly reduced retropulsion and minimal periorbital swelling. So when they enucleated this, this eye came along with a very large orbital mass that was very firmly adhered to the sclera. And so when we grossed it, we decided to leave that mass attached to the eye, and then we hemisected it. What I do want to point out is that we have recognizable sclera on this side of the eye. And then when you kind of follow it around here, all of a sudden that sclera actually seems to get really expanded. And then also it's just very hard to make out. And then also the uveal tract, like the choroid here, is also, and the ciliary body are also expanded. So this is kind of an interesting set of lesions in this eye. All right, I'll do the subgross thing on this one. All right. And there we go. Okay. So here's the cornea. It's actually, I think there might be a corneal ulcer, but that's the least of this globe's problems. We got the lens, also pretty normal. The iris itself is pretty normal. There is actually an infiltrate in the iris, which we might have time to touch on. And then when we move into the orbital tissue and that thing that's attached to the eye, it's just greatly expanded. The sclera is really sort of disappears and is blended with this infiltrate. And then whatever infiltrate it is kind of extends out into the orbital tissue as well. On the other side of the eye, the sclera is also abnormal and it is expanded, although it is still recognizable. And then you can also see that whatever infiltrate this is, it also extends into the subjacent choroid, and also that the ciliary body is also a little bit more purple than it should be. So there is also a ciliary body infiltrate. I'm actually going to go to a different slice of the globe. I'll just show it real quick, which will give us a little bit better morphology of what's going on here. So we have cornea right there. We've got iris, ciliary body, and then here's that greatly expanded tissue. So from LOMAG, I just want to point out that we have scleral collagen, some of which is still kind of the normal eosinophilic, fairly eosinophilic color. And then some of it is much paler eosinophilic, so that's a little bit abnormal. And the elements of the sclera are separated by a cellular infiltrate. And it also seems to cluster, that infiltrate also seems to cluster around blood vessels. And the infiltrate itself gets a little bit more dense in some areas. We'll just go ahead and dive right in. This infiltrate is not really forming any structures, which is either suggestive of a round cell neoplasm or a non-neoplastic infiltrate. When we go higher mag, we can see that it is actually quite a heterogeneous cell population. So we have a lot of cells that are kind of spindle-shaped with big nuclei. These are probably a mix of histiocytes, so macrophage origin cells, or fibroblasts, which are the ones that create the extracellular matrix. And then we also have a large number of round cells. Some of them have very little cytoplasm, like this guy right here. It's probably a lymphocyte. Some of them have more cytoplasm and a perinuclear clear zone with an eccentrically placed nucleus. That's probably a plasma cell. And then I think as we move around, here's actually probably a plasma cell with Russell bodies. So that's a Mott cell, constipated plasma cell. So this is indicative of chronic inflammation. And this, what we're looking at, especially with the fibrosis, with all the fibroblasts and that all this pink fibrillar material here, which is collagen. So this is a very chronic inflammatory lesion. Some of the larger cells can be multinucleated, like this one right here. So we have a histiocyte-rich inflammatory lesion. And then it is dissecting between, separating, etc., the elements of the sclera. And then when we move into the globe, it's a similar infiltrate in the uveal tract. So we have in the uveal tract, it's maybe a little bit more lymphocyte plasma cell rich. So those are the most important lesions of this case. And so now I'm just going to go back to my diagnoses to talk about the differentials here. So my diagnosis was severe extensive histiocytic and lymphoplasmacytic scleritis, episcleritis, and orbital cellulitis. There was also a keratitis and a panuveitis, so the entire uveal tract as well. I did a fungal stain because a fungus is the most typical microorganism to lead to histiocytic inflammation. I did not find any fungi. So this is idiopathic inflammation. So I'm not quite sure if this is granulomatous scleritis versus reactive histiocytosis or a mix of both. So granulomatous, which is also known as necrotizing scleritis, is where simply, or not simply, but just the inflammation is isolated to the sclera. And it can be really severe and it greatly expands the sclera. Sometimes that inflammation will extend into the uvea, but not very often. Sometimes it does. But this case also has this really extensive orbital component of this inflammation, and some of the sclera wasn't as affected. So I'm not sure if this is some sort of other idiopathic histiocytic orbital inflammation that we generally wave our hands around and call reactive histiocytosis. And I understand there are problems with that as far as the strict definition of reactive histiocytic lesions. But whatever this is, it's histiocyte rich, and it's idiopathic. So whatever you want to call it, I don't know. But I kind of think it's a mix of these two different conditions, which makes it kind of an interesting case. Any questions? I think we're done. All
I
right.
don't think so. Yeah, we're all confused about those. So
Yeah. Yeah. I should say that the granulomatous scleritis or necrotizing scleritis can be bilateral, and they said the patient's other eye is totally normal, which is not unusual for cases that we receive that we diagnose with granulomatous scleritis. Oftentimes, that seems like the other eye is normal. We assume this is some sort of aberrant immune response, exuberant. Maybe there was an antigen present at some point, but it's gone, or we don't really know. So anyway, that's it. Thank you. Enjoy your Wednesday.
take care, everyone. See you guys in 2 weeks.
Bye-bye.